want to thank our panel. So you've just heard from two outstanding physician leaders in reforming healthcare, and I can't think of a better way to close out our day than our keynote speaker, Dr. Bill Cassidy, Senator from Louisiana. You all have his bio in front of you. If you don't know already, he is a liver disease specialist physician who has long been involved in care for underserved populations in Louisiana, and also long been involved in a commitment to improving health and health care through public service now in the Senate. We've talked today about a lot of approaches to by which states and the private sector can innovate in Medicaid, in state insurance exchanges, and through other mechanisms to get to better health and lower health care costs. Dr. Cassidy is going to give us some remarks to put that into, I think, our current political context and his leadership on these issues, and then we'll have a little bit of time for discussion. Dr. Cassidy, very pleased to have you with us today.
You always want to come into a talk and have a little bit of energy, a little bit of anxiety, if you will. I have that. I think Mark just told you I was going to be speaking about something of which I am not prepared. So let's hope it still goes well. I am a doctor. Can you turn off that slide for a little bit, please? I'll just ask you to bring it up when you can. I am a doctor during the camp. I'm a gastroenterologist, a liver specialist. Most people don't know what a hepatologist is. That's why Mark said a liver specialist. When you say a hepatologist, people think you either do snakes or venereal disease, and so it's just confusing, so we just go with liver disease. But my background is having worked for a charity hospital, we call them in Louisiana, for about 30 years, teaching with LSU Medical School, doing research teaching, working in a prison setting. And my focus has always been either the uninsured or Medicaid patients. I always ask patients, it begs the question, why are Medicaid patients being seen in a hospital for the uninsured? And of course, anybody who knows Medicaid knows that it pays providers poorly, at least physicians, and so as a rule, physicians don't see Medicaid patients. And that just began my kind of interest with it. So when I entered the state Senate in 2007, subsequently Congress, I've maintained that interest. Let me first thank Mark and the McKinsey group for being here. Way back when Obamacare passed, McKinsey came out with an article, The Three Imperatives of Controlling Healthcare Costs. One, to decrease the burden of administrative expenses, to decrease the burden of chronic disease, and price transparency. That has stayed with me ever since, and our reform efforts have always tried to implement those three things because as a practicing physician, I always knew just how important those were. Now, the outline, if you will, of what I will speak about will be the federal-state relationship, which is principally Medicaid. I'm sure you've heard of it, but let me give you my perspective, and perhaps different from those who've already been here. I would say that the federal-state relationship in Medicaid is pathologic. That it is pathologic because the federal government keeps tempting the state into doing things it should not tempt it to do, but the state, like any good person being tempted, easily succumbs, and then discuss an approach that may actually address this because so much is at stake, including those patients I used to care for in our Louisiana charity hospital system. Now, I just saw a headline. My staff gave it to me yesterday. Oregon, some lawmakers are considering discontinuing the Medicaid expansion because the expansion, because they cannot afford the match. Now, right now, that's about a 97.5% to 2.5% match. And there's about, I'm told, 350,000 people on the Medicaid expansion in Oregon, and that 10% match is going to eventually cost them $235 million. Now, that's quite remarkable. A blue state that has really pushed out there trying to expand Medicaid, and at least there's a proposal that even a 90% match is not good enough. Now, why is that? Well, first, let's just start with traditional Medicaid. We all know the FMAP is typically 60%, the state match is about 40%, and this has continued for quite some time. And that 60% always tempts the state to pay more. It becomes economic development. And you indeed will hear governors talk about the need to balance the budget. That's why they expand Medicaid. or the need to have economic growth, and that's why they think Medicaid is such a good program. But it has consequences. If you'll put the slide up, please. Now, this is something which I just want to show. I don't have a... This is 1990. This is higher ed financing. If you went back to 1964, it would look like that. And here is Medicaid. And here, if you went back to 1964, it would look like that. And as Medicaid programs have grown, it has cannibalized other programs. So much so that by 2014, expenditures on higher education, which had started here, are down to 9.4%. The state funding is up to 19.1%, and this is projected to continue to grow, and states are continually backing out of their financing of higher ed. This is just one program, but there is a cannibalization, and this being somewhat driven by the FMAP. Why do I say that? When I was in the state Senate, we would speak about decreasing Medicaid, and it would be brought to us. Wait a second, if you decrease, in our state at that time, we're getting about a 65% match. So imagine that they came to us and they said, we can save $35 million in state general fund by taking it out of Medicaid, but you lost $65 million. And so trying to subtract from something with such a generous match, incredible impact upon your state budget, number one, but also an impact upon those who provided benefits. I can promise you the American Hospital Association, the nursing homes, the physicians, everybody who was a provider would come and tell you why those cuts couldn't be made and lobby that they shouldn't be made. But nonetheless, the state is tempted into abandoning its support for things like higher ed in order to otherwise support Medicaid. Now, let's continue with the temptation. I feel like we have really got something here. If you look at on traditional Medicaid, currently, the amount of money being spent by the combined federal-state contribution is about $4,200 to $4,300 per person, okay? That's not long-term care nursing homes, that is the medical patient. The average expenditure on somebody in the Medicaid expansion population, in which the federal government pays 100%, is $6,300. The federal government and the state together is putting up 50% more in the expansion population than in the traditional population. You can imagine why. The federal government paid 100%. People back home in Louisiana would say, it's free money. I mean, literally, like the cartoon you would see at nighttime TV with a guy in the green suit with the dollar bills poking all over himself. It's free money. And that was the mindset. If you look in Louisiana, we enrolled 450,000 people into Medicaid expansion within 18 months, whereas the average nationwide is $6,300 per participant. In Louisiana, it is $6,700 per participant. When we go to a 10% share, Louisiana will be on the hook for $310 million. Now, we are having a budget crisis right now because of a $310,000 budget gap, but this will be added to that $310,000. Out of curiosity, I looked up California. I think they'll be on the hook for, at 2015 numbers, they'll be on the hook for their 10% will be $1.2 billion. Now, Peter Lee is in the front row. I suspect $1.2 billion is just chump change around Sacramento, huh?
Send me the bill.
Yeah, that's a line item that says Peter Lee's retirement. The point being that because the federal government paid 100%, states succumbed to the temptation to pay top dollar for these patients. Why do I say top dollar? We got Blue Cross Louisiana to tell us what the cost would be for a 35-year-old in Louisiana for 100% actuarial value, Blue Cross Blue Shield policy, roughly $6,100 to $6,200. Our state, on paying Medicaid rates with a Medicaid provider panel, is paying $6,700 for that 35-year-old. Now, I may have my numbers a little bit messed up right there, but I can tell you when we calculate it, our state is paying 100% actuarial value for a Blue Cross Blue Shield patient. And that's why I say the states are tempted. Because it's free money, they are incredibly generous. But that generosity has set up a situation where not driven only by the numbers enrolled, but by the amount per enrollee, states are going to be on the hook for sums they cannot manage. And so if Oregon is saying our 10% is too much for us, someone else in Oregon will say, but wait, if you cut that $235 million, you're going to lose $2.4 billion. That's going to be a hard conversation. Now, I would argue that if the problem, and by the way, this has consequences for the federal budget. As we all know, entitlements are sucking up our federal budget, crowding out other funding as well there. The federal Medicaid budget's currently about $545 billion and expected to accelerate in growth. We can also point out that financial gimmicks are used by states to try and pay down their share of the state match. There's estimates that it's about $33 billion in the intergovernmental transfers and about another $33 billion in provider taxes, all used to pull down federal match. But increasingly, the federal government attempts to limit that, which again puts the state more on the hook. It's estimated that these gimmicks pull down $150 to $200 billion in federal financing that would not go to the state, with the state putting up true state general fund dollars. Now, if I'm going to say that relationship is pathologic, can you go to my next slide, please? I think it's because we have misaligned incentives under the status quo. And usually in healthcare, that is the problem. This slide may be small to you in the back, but let's look at this. If this is the incentive to decrease cost, the federal government is incentivized. It does not want to pay more. The state is somewhat plus minus. If you are getting 100% federal financing, frankly, you're going to be very generous to those with whom you contract. But do providers care about decreasing cost? Probably not as much. Maybe they get a quality bonus from a well-run Medicaid Advantage program. Do patients care about decreasing cost? No. As a provider, as a physician, I can tell you anecdotes of people who go to the emergency room to get a pregnancy test. Something that would be $15 in the pharmacy, they walk out with a bill minimally $500, but you can imagine it would be more. So patients have no incentive to decrease cost. What about the incentive to combat fraud? Of course, the federal government wants the fraud rooted out. If the state goes after fraud, it has to give back to the federal government's share. So if you're a 70% FMAP state and you recover fraud, 70% of that goes back to the federal government. That being, of course, a disincentive for the state to go after fraud. And for providers and patients, as a rule, it does not matter to them if anyone goes after the fraud. In fact, the providers might be threatened by it. So I think these kind of misaligned incentives are part of the problem. The answer, of course, is begged, and that is to align the incentives. Now let's go to a bill we put forward, which I put out there not for bragging rights, but just to kind of further the discussion. Could I go to the next slide, please? We have something called the MAC Act. I forget what MAC stands for, but obviously it's a reference to Medicaid. The Medicaid Accountability and Care Act or something, which we introduced a few years ago, but which actually has become the basis of a lot of Republican proposals and which we continue to include in our proposals. In our MAC Act, we institute what we call the per beneficiary payment, but others call the per cap cap. Now, I can tell you, if you mention a per cap cap, even in a group like this, there are going to be some who immediately say, oh my gosh, we are going to rob patients of their health care. And you can certainly say that's going to happen if I'm on Capitol Hill. But let me give you a little history of the per beneficiary payment or the per capita cap. It began in the early 90s with Bill Clinton on the left and Santorum and Phil Gramm on the right proposing this. When my staff and I wrote this legislation, I think it was 2010. No, 2013. 2013, the Medicaid director of California was coming up with the same proposal. And I remember bringing somebody in to look at our proposal. And he said, "Are you working with the NGA?" And I said, "No, not really. And why do you even ask this?" Howard Cohen, I think, asked me that. And I said, "Well, why do you even say that?" He goes, "Because they're having a meeting right now in Chicago, 6 Democratic Medicaid directors, 6 Republican Medicaid directors, and a meeting hosted by Tom Daschle to propose a per capita cap." And it was kind of convergent evolution. There was a problem, and folks were all coming together. Now, I have a sense, I'm not quite sure, that the Obama administration got wind of what was happening in Chicago, knocked it down, dispersed it, threw it to the winds. Just because it seemed somewhat disrespectful to the effort they were making. But nonetheless, I go through that to point out that it actually has origins on the right and the left, and is seen as a reasonable way to address the lack of the malalignment of incentives that are working against both the federal and state government. And if I had a longer period of time, I would say also on behalf of the patient. So first, let me differentiate a per beneficiary payment from, because there'll be some in here who say, "We don't like the per beneficiary payment, we want a traditional block grant." First, let me address the traditional block grant. I think the traditional block grant is a lousy idea. And I say that because if you just take historically what the state has received and they continue to receive it, then those states which have gamed the system, and all have gamed it, but some have really gamed it, those that have gamed it are rewarded, and those who have not gamed it so much are penalized. That's not fair, number one. Number two, there are incredibly different and changing demographics to states. The best example I can give, after Hurricane Katrina, Louisiana lost maybe 25 to 50% of its Medicaid population. They went to Texas and Georgia and all over. If we had been stuck in a block grant, Louisiana would have continued to receive all the money it received before we lost 500,000 Medicaid recipients. But Georgia and Texas would have been penalized. On the other hand, as they begin to come back in, those folks begin to move back home to Louisiana. Frankly, the payments to our state lagged behind, and so we had a little bit of oh my gosh, we're not getting enough, because folks were moving back, but the kind of adaptation to their moving back in terms of federal payments was delayed, and we ended up having some hard fiscal times because of that. But that said, if it had been just a traditional block grant, what you get is what you always get plus an inflator, then we would have done great with that, but Texas and Georgia not so much. Secondly, demographics change. New York has a declining population. Texas just picked up 3 million people in the last decade. Many of those folks would qualify for Medicaid. And so if, again, you have a traditional block grant, then those that are growing in population are penalized, those shrinking shrink. Lastly, I will say that some populations age more than others. So Vermont, Florida, Pennsylvania, elderly population, lots of blind and disabled long-term care, obviously their costs going up. In Utah, it seems every Utah family has 10 kids. They're young and they're healthy. So you obviously want your cost basis to reflect the health of your population. So what we propose in the MAC Act is a per beneficiary payment, but you break it down into 4 categories. You break it down into long-term care, blind and disabled, children, and adults. Very different cost basis for each. And you would have, over time, if this is the 51 jurisdictions taking Medicaid, including Washington, D.C., you would have a scatter graph, and over 8 to 10 years, everybody would move down into a mean plus or minus 10%. So if you have somebody really paying a lot for long-term care, but it doesn't seem justified by a geographic difference in expense or disease burden, they would gradually move down. But on the other hand, a state that was not getting as much money could come up. I'm actually establishing a different paradigm here. The paradigm is that the federal government is going to make a guarantee payment for someone in poverty's health care no matter where they live. And so it becomes Again, a patient-level guarantee, not a state-level guarantee. Let me see what else. We would increase a state's FMAP, but we would do away with the ability to use financing gimmicks. We actually think we would hold states harmless. By the way, the power of these financing gimmicks, I spoke to someone, he says that his statutory FMAP is 63%, but his effective FMAP is 80%. Another whose statutory FMAP is 70%, but their effective FMAP is 90%. So these intergovernmental transfers, provider taxes, and other mechanisms really do pull down a lot of extra federal dollars. We would increase the FMAP, but do away with those financing gimmicks. And we think between the per beneficiary payment, you're going to get this much money, and you can't use gimmicks, we would begin to create a stable system in which the state would be incentivized to be wise managers of the dollar, not just spend it because it's cost plus contracting. We would also allow states to keep 100% of recovered waste, fraud, and abuse. So as opposed to having giving the federal government back 70 to 80 or 90%, they keep it all. Because they're getting a set amount per beneficiary, why would they not be aggressive at recovering the waste, fraud, and abuse? And lastly, if a state did a great program and they lowered cost, my state has a high amount of obesity, which in of itself engenders a lot of healthcare spending. What if we came up with a tremendous program that actually decreased the incidence of obesity, therefore the manifestations of the metabolic syndrome? Well, we would spend less money on caring for those patients, but we would allow the state to keep that money to put back in to some other healthcare program. We think we incentivize them in that way to address what McKinsey identified 7 or 8 years ago, which is to decrease the burden of chronic disease. We incentivize the addressing of chronic disease. So let me finish, and then I'd love to take questions if any have. Again, I think that the relationship between the federal government and the states is pathologic. States constantly tempted into spending more money because the federal government hangs out such a generous match. But we find that even a 90-10 match will not be sustainable. Partly, this is due to the misaligned incentives. It is just inherent in the way this program is structured. But we think that if we align those incentives, and we think the best way to do that is through a per beneficiary payment, we can actually address this. One more thing I should say. Folks assume that a per beneficiary payment is less generous than what a state would currently receive. Under our proposal, the state continues to receive that which it has. It's just that we anticipate that savings from the bending down of the cost curve. So it isn't so much that we immediately claw back dollars, it's just that we think the incentives being aligned means that there will be cost savings in the future, and those will amount to a large, we think that will amount to a lot. I'll look at my staff. Did I leave anything out? Well, thank you all very much.
All right, thanks, Senator Cassidy. Actually, that was right on target with the themes for the conference, especially around the support for long-term improvements in health, population health, and healthcare efficiency. We did have a lot of questions, though, also about some short-term issues, especially around repeal and replace of the ACA and the uncertainty that's creating. While if there are any questions, please come out to the microphones. But while you're doing that, any thoughts that you have about where this is all going to end up?
No, well, I have thoughts, of course. You know, candidate Trump ran saying that he was going to maintain coverage, care for those with pre-existing conditions, lower premiums without mandates. Now, again, we have a bill out there, the Patient Freedom Act, known colloquially as the Cassidy-Collins bill, and we think we accomplished that. We also think we accomplished the complexity by, frankly, delegating back to states with some guidelines. Ours is not yet accepted, but I'm not sure that the House proposals are yet to be accepted. The House sacrifices coverage, and that's where they get their savings. I think candidate Trump's pledges are not fulfilled, but I can tell you that Mike Pence and others are working the Hill. Brian Blaze is coming to speak to folks. They're trying to convey it. I just don't think it personally works.
Okay. Peter.
Yeah, Senator Cassidy, great presentation, incredibly thoughtful. And I'm actually not going to talk about repeal or replace. One of the elements you didn't talk about in the MAC Act is incentive alignment on the provider side. But I think it's absolutely true. My experience is providers will always want more and protect their turf. Can you talk about specifically how there's a better alignment of incentives under that act for providers and how they stand to gain with more value and efficiency? Because that's one of the great failures I think we have in the healthcare system generally.
Yeah, so one, a well-run managed care company, of course, is going to align incentives for providers, right? Fair statement. Secondly, I think that one thing we allow, by the way, is the state to take their Medicaid expansion population, we do that in the Patient Freedom Act, to take their Medicaid expansion population and transition them with different benefit design into the private insurance market. So a provider group, for example, going to two-sided risk would be able to take that on. And once you have two-sided risk, I think you align incentives. But I think, again, insurance programs are increasingly moving to that sort of two-sided risk model. Not always, but I think they are, because that's the only way you align those incentives. But, I agree with you totally, Peter. You got to align the incentives.
Hi, Joyce Frieden from MedPage today. I was wondering, there was a lot of talk about value-based payment and alternative payment models today. And so, Senator, I was wondering if any of your legislation would encourage those types of models.
Yeah, well, first, we know the current law has a lot of encouragement for such models. But we try and be as bare bones as possible, delegating to states. Let me start over. I am going to speak now as a physician who worked in a public hospital system. And I found that if the patient had the power, the system lined up to serve the patient. If the patient didn't have the power, she'd be like flotsam and jetsam, tossed this and that way by the waves and the sea and the wind. So under our proposals, we very much favor the patient getting a certain account, pre-funded health savings accounts, with a catastrophic or a high deductible health plan and a pharmacy benefit. And then she chooses the policy. Now I'm kind of melding our Patient Freedom Act with our Medicaid reform bill. And then she chooses the coverage she wants. There's a lot of data out there that when the patient is empowered to control her spending, she controls her spending. The Medicaid waiver that Indiana received, Indiana Plus, is the latest example. But there's a lot of other examples of when the patient controls the dollar. We also couple that with price transparency. Which again, way back when, McKinsey said this is what we should do. And if you have price transparency coupled with the patient having ownership, we think she is empowered to make wise decisions. Now, at that point, you begin to restore a market. We want value-based purchasing. So the patient should have the ability to say, oh, my daughter's been prescribed a CT scan of the abdomen. Do a scan, do a little app, scan your app. It could be $250 here or $2,500 there. Over here at $250, I have to go midnight at Thursday. Well, baby, we're staying up Thursday night, because we're going to save that money. I picked $250 and $2,500 because there was an LA Times article. The cash price for a CT scan in LA Basin a few years ago varied between those two numbers. So once you have price transparency, I think you begin having a normal marketplace. And another example, my state, they passed a law that a PBM could not gag a pharmacist on what the cash price of a drug would be. Because there were people coming in to get medicines. If they paid cash, they would pay 1/3 of what they would pay through their insurance policy. But there was a gag contract that would not allow the pharmacist to tell the patient that. So again, I think once we restore normal market forces, we can do that. We also believe in all the other things that people speak of regarding value-based purchasing. But I think the missing element so far is empowering the patient and giving her the information she needs to purchase value.
Thank you.
Senator Cassidy, thank you very much for your leadership and for joining us today.
Thank you.
All right, we are just about done. We have covered a lot of ground today related to state and private sector innovation in Medicaid and in state programs and individual insurance markets, including topics that have ranged from how to support fundamental changes in care and public health to the timing of the rate filings and risk-adjusted rate updates in California. It is all related, and while that might seem complicated, and while the politics certainly is complicated as well, there are some clear vital directions and imperatives where we think real progress is possible. So you've heard a lot of views on these issues today. I want to thank our fantastic speakers again for sharing their insights, sharing their perspectives on the future of the healthcare system and innovation in improving it and navigating through change and uncertainty. We really appreciate all of these perspectives, especially at such a critical time for the future of healthcare in America. Just a reminder, too, though, that the views expressed here by all of our participants are their own. They don't necessarily represent the views of the Duke-Margolis Center for Health Policy or the McKinsey Center, or McKinsey and Company as well. I also want to thank McKinsey's Center for U.S. Health System Reform, which is their source of expertise on these reform issues, as well as the staff and faculty at the Duke-Margolis Center for Health Policy for making this event possible today. Both McKinsey and Duke-Margolis share the goal of supporting public, private, social sector innovation to transform healthcare and the policies that can enable that based on better evidence and more knowledge and sharing all of it. So in that spirit, the recording and video from today's event will be available on our website at healthpolicy.duke.edu, the Margolis Center website, and also at the McKinsey website, healthcare.mckinsey.com. The materials related to today's discussions are all available, will be available on the web, also are at the front desk if you haven't gotten a copy already. And please do keep in touch with us, follow what's going on with the websites. We're going to keep working together on taking steps to address these critical issues of improving health and getting healthcare costs down. In the meantime, thanks again for joining us in this discussion today, and we hope you have a great rest of the afternoon. Thank you.